Good morning. I'm gonna give this a practice try. There we go. All right. Got my tutorial from the previous speakers. All right, so I'm going to take the role of Dr. Savar here at the beginning and point out to Peyton that you could have saved some money this morning by getting your Starbucks coffee right outside. There was also free water. I am not a physician. I cannot advise people on how to save money on drugs and which drugs to take, but I do know free Starbucks could get is a better deal than the Starbucks you got around the corner somewhere. So it really is an honor and a pleasure to be here to talk about this important issue of the cost of oncology drugs and oncology and cancer care. What I like to do when I speak to a group is provide what I would consider a tutorial on how the law and regulations work, because it illustrates why we may pay the way we do at the Medicare program and some of the limitations that we have in changing the way that we pay for services. And I think, as somebody said previously, it often takes an act of Congress to change the way we pay for something. I mean, there is certainly some discretion and authority within CMS, but certainly limited by the statute. In order for Medicare to pay for any item or service, it must have something called a benefit category. These are listed in the statute. There's going to be a specific provision, and within that provision, we will decide whether an item or service falls within that benefit category. So the ones that are probably the most common to oncologists are going to be physician services. Physician services describe what a physician does, anything a physician does. The other one, or the next two, are going to be Section 8, or at least relevant to this discussion, Section 1861 S2A of the Act, which are services and supplies, including drugs and biologicals, which are not usually self-administered by the patient, furnished as an incident to a physician's professional service of the kinds which are commonly furnished in physicians' offices. So what these are Part B drugs. Drugs that are self-administered are Part D drugs. So this was the benefit category for oncology drugs for most of the years of the program. We didn't have a prescription drug program in 2005, I guess, with the Medicare Modernization Act. We did get a Part D prescription drug program, and then drugs that were taken orally could be covered under a different benefit category. A related benefit category is Section 1861 S2B of the Act, which are incident to hospital services, and that would be Part B drugs that are administered in hospitals. So each of these benefit categories, that's the benefit category provides the provision of a law that allows us to pay for the drug or service. Then the next provision of statute that we look at is what is the item, what is the statutory provision that provides for payment for that item or service. So I described before 1861 S1 physician services. The payment methodology for those services is the physician fee schedule, Section 1848 of the Social Security Act. Incident to drugs, which are furnished under the direct supervision of oncologists. I had said previously before, the benefit category is going to be 1861 S2A if they're incident to a physician service, 1861 S2B if they're incident to a physician service in a hospital. And the payment methodology is going to be, for drug administration, is going to be physician fee schedule or outpatient prospective payment system. So this is the administration itself. So this is the injection or infusion of the drug. And then the drugs themselves are going to be incident to a physician service, incident to a physician service in a hospital, and the payment methodology is going to be 106% of average sales price, what was previously described. These are the sales prices by the manufacturer to all payers, averaged 6% added. So some of the history here, physician services and drug administration. Prior to 1992, they were paid under something called reasonable charge, and that was a complex methodology that was in effect from 65 until, or 66, whenever the Medicare program started, until 1992, and I think it was part of a a political deal to get the Medicare program enacted that we would allow charging practices in the local areas to remain in effect. And there was a complex methodology based on whether it was the prevailing charge in the area, the physician's customary charge, the actual charge, and then there were some limitations on charges over time that were put into the statute, but essentially froze in what payment rates were in 1966. In 1992, until the present, we went to the physician fee schedule, and that got rid of all of the charge differences, came up with what is known as the resource-based relative value scale, estimate the resources involved in physician work, practice expense, and malpractice for 8,000 or so services that are paid under the physician fee schedule, come up with a national payment rate, adjust for area differences in cost, and then multiply by something called the conversion factor, and that determines the physician fee schedule amount. Incident to drugs, prior to 1997, we paid on the lower of estimated acquisition costs or average wholesale price, which in the regulations was the median of the generic and brand name for multi-source drugs. From 1997 until 2003, we paid based on 95% of the average wholesale price, or wholesale price for single-source drugs, or the lower of 95% of the average wholesale price or lowest brand name drug for multi-source drugs. Beginning in 2004, we went to 85% of average wholesale price, and beginning in 2005, we went to 106% of average sales price. I'm going to talk a little bit about why, what average wholesale price was. The issues that I think we found with average wholesale price are illustrated in this slide and the bullet points in this slide. Spending went from $400 million for these drugs in physician offices to $7 billion in 1992. In 1999, up another $1 billion, from $7 billion from 1992 to 1999, up another $1 billion in 2000, and up 26%, $1.5 billion from 2001 to 2002. MedPAC, in its report in 2003, attributed the growth to the increased volume of drugs used and the substitution of new and more expensive medications for older therapies. General Accounting Office and the Office of the Inspector General were also looking at these issues during this time period, and they showed that the current Medicare payment method leads to payments that far exceed a provider's costs, and the largest amount of payment went to these specialties: hematology, oncology, medical oncology, and urology, which received 58% of Medicare's Part B drug spending. So when I say we paid estimated acquisition cost or some percentage of average wholesale price, the reaction is, well, how can that possibly lead to all of this utilization and profit incentive? So at least with average wholesale price, we looked at pricing compendia to determine what the average wholesale price was, and then paid average wholesale price or some percentage of average wholesale price. But that was not the price that the oncologist got the drug for, or whomever was administering the drug. It could have been a urologist or another type of physician. They actually got the price much less. So the average wholesale price was a price that was reported in these pricing compendia that Medicare paid. Either the local contractors referenced the price in the pricing compendia, or at a later point in time we went to what was called a single drug pricer, where we calculated a national price across all Medicare contractors. But the issue was the same. The average wholesale price reflected in the pricing compendia was not the price that the drugs were actually furnished for. So there was what was called a spread or margin on those drugs, and coincident with the average wholesale pricing methodology, beginning, I guess, and estimated acquisition costs, beginning in 1992, saw a lot of movement from hospital outpatient departments or hospital inpatient care to care being first furnished on an outpatient basis in physician offices. So beginning in 2004, because of all of these reports by MedPAC, the Office of the Inspector General, the General Accounting Office, and this was a multi-year effort to changed the way Medicare priced drugs, not just oncology drugs, all Part B drugs, which actually would include inhalation drugs as well, that were paid prior to the advent of the Part D program and still are paid under Part B. Changed the payment to 85% of average wholesale price in 2004, and then 106% of average wholesale price beginning in 2005. I think the 85% of average wholesale price was really intended as an interim step until we went to a new pricing mechanism. And the way average wholesale prices, as I mentioned before, the manufacturers report what all sales, all sales, all classes of providers, they report it to CMS, and then CMS at the J code level or at the HCPCS code level will determine what the average sales price is among all of those drugs and add 6% to it. So oncologists during this time period, probably around prior to the enactment of the Medicare Modernization Act in 2003, certainly conceded that the drugs were overpaid. But they argued that overpayment was necessary to subsidize underpayments for drug administration and all of the services that were associated with providing oncology care in a physician's office. So the Medicare Modernization Act, what it did was move us from AWP pricing to ASP pricing, and also changed the price for administration. A lot of this was done. There were a lot of very specific provisions in the statute which directed us exactly how to increase the price for administration. And then there were some other provisions that were more general, which made it clear that the price of drug administration should increase, but gave us more authority to develop codes and determine exactly how that price increase would occur. So what I've done here is just provide an illustration of a couple of services. This comes directly out of Federal Register publications, so the final physician fee schedule regulation at the time the rule was published, of some common services that were performed in physician offices to administer drugs. So a therapeutic injection, which would be just a simple injection, went from about $4 in 2002 to about $18.50 in 2005. And one of the reasons I'm going to 2005 is because I think, well, I guess there were some temporary increases in payment under the statute that expired. I believe these are intended to show this without that temporary increase in payment. Excuse me. And the first hour of chemotherapy administration, and this would be the type of administration service that's more commonly done by an oncologist. The therapeutic injection would be done by an oncologist, but could also be done by many other types of physicians. First hour of chemotherapy administration went from about $56 in 2002 to over $172 in 2005. Payment in the hospital outpatient department, which is the other relevant place where these services are provided. Prior to 2000, drug administration was paid on something called reasonable costs. These were hospitals have these things called cost reports, very detailed, sophisticated accounting documents where they report their costs. And Medicare had a process where we would look through their costs, figure out what Medicare's share of those costs were, audit the costs to make sure that they were reasonable, as the title suggests, and then determine what share of those were attributed to Medicare patients and pay those. Not a particularly efficient payment system. When you tell people you're going to pay them some percentage of their costs, naturally costs go up, and that's what happened on the inpatient side as well. And over time, there were movements to try to get from reasonable cost payment systems to prospective payment systems. Analogous on the physician side were reasonable charge systems going to physician fee schedules. From 2000 until the present, we've been paying for drug administration services and most other hospital outpatient services on the basis of the outpatient prospective payment system. Incident to drugs, so drugs administered incident to a physician service in a hospital, prior to 2000 were paid based on reasonable costs. From 2001 to the present, what we have been doing is packaging them based if the estimated cost per day were lower than a particular threshold, so $90 in 2014. Then if they were over that threshold, we were paying an average of estimated costs for all separately paid drugs expressed as an ASP equivalent from 2001 to 2012. And my staff and I debated this particular point, and they said it's not precisely accurate because it was estimated acquisition costs, but they were always bouncing around and we were always transitioning to whatever the new estimated acquisition costs are. And I argued back, I said, well, if I do that, this is going to be like a 20-page slide just on this one particular point. I'm just going to say it's kind of generally accurate. Rough justice here. We paid based on estimated acquisition costs, sort of always moving towards that goal of what hospitals reported as their estimated acquisition costs. In 2013, we finally gave up and said, forget it. We're just going to pay 106% of average sales price. And I have to say, I think probably to any of you out there who are affected by this payment methodology and to my staff, what a relief. That was very nice. We don't have to do that anymore. This is probably going to be reported in some newspaper somewhere. This will be my last public presentation. So far, so good. I'm usually a little bit glib in these presentations, and I'm continue to be invited out. So go figure. So far, I haven't said anything too terribly awful. So in physician fee schedule, so I think one of the prior speakers did mention how payment has changed under the physician fee schedule for drug administration going back, I would say probably from 2005. Large increases between 2003 and 2005 for payment for drug administration under the physician fee schedule. And then over time, there has been an evolution in the payment, which I think has largely caused it to come down, and it does for particular reasons. So as the first sub-bullet shows here, the first hour of chemotherapy administration went from about $161.50 in 2009 to about $147,000 in 2010. And the reason for this was something called the Physician Practice Expense Information Survey. Without getting into all of the complex details, we were paying for physician fee schedule services based on a very large survey of physician practices called the Socioeconomic Monitoring Survey that was done by the AMA. They stopped doing that survey. We went for a number of years without having survey information to update physician fee schedule rates. We then got a new survey, multi-year data collection from the American Medical Association and its member specialties, and decided to use that survey. It created a significant change in payment, budget-neutral changes in payment, very redistributive. The largest reductions occurred to cardiology, about 10%, oncology, 5%, and some of the other specialties here. And I think the specialties here all had, I think, a common denominator, and that is we were using the Socioeconomic Monitoring Survey to price the services that they do, and they submitted what was called a supplemental survey without knowing that we were going to use this survey data to price services beginning in 1999. These specialty argued that their costs were not represented in the Socioeconomic Monitoring Survey and did a supplemental survey under some regulations that we had adopted in response to some other provisions of law. And what happened when those surveys were done was they caused payments for those specialties to go up. When we went to the Practice Expense Information Survey, a multi-specialty survey across all specialties, and either stopped using the supplemental survey or incorporated the supplemental survey into, I can't remember exactly what we did, but that caused payments for these specialties that had done these supplemental surveys to go down. So it's possible that the adoption of the Practice Expense Information Survey accelerated the purchasing of physician practices. So MedPAC had noted that echocardiograms declined 9.9% in physician offices, I think that's total payments, and increased 33.3% in hospital OPDs from 2010 to 2012. So what that does is correspond with the time period when we adopted payment changes based on the Practice Expense Information Survey. So a lot of interest now in comparison across sites. So physician offices, we pay for physician fee schedule services at what we call the higher non-facility rate, to recognize that the physician incurs the cost of the supplies, expenses, medical supplies, medical equipment, and clinical labor. But there's no payment for facility services, and the beneficiary coinsurance is going to be 20% of the physician fee schedule amount. So if you go to a physician office, you pay a higher physician rate, 20%, that's it. If you go to the hospital outpatient department, we pay the physician less because the hospital is now incurring the cost of the staff, supplies, and equipment, but we pay an additional fee for the institutional or facility service that's provided by the hospital, and the beneficiary coinsurance amount is going to be 20% of the physician fee schedule amount, and 20% potentially higher because of the artifact of how the outpatient prospective payment system works, of the OPPS payment amount for facility services. So there's going to be an additional coinsurance amount. And then there's also going to be the 20% coinsurance amount on the drugs itself. And I think hopefully this is my, oh, okay. I see the red light blinking, and I'm very sensitive to the fact that I may be over time, but I'll do my best here to go through the remaining slides. MedPAC has been sensitive to this issue and has looked at it, and they've said we pay, actually I'm going to go back one to the provider-based rules. There's a lot of information in this slide, but suffice it to say, what happens under the provider-based rules is that a hospital can purchase a physician office. They can attest, or even not attest, that it's provider-based, which means they're saying that it meets the conditions of participation, and they can start billing as a hospital. So MedPACs in 2014 said there has been a rapid growth of hospital purchases of physician practices, citing AHA data that hospital-employed physicians grew 55% from 2003 to 2011. There could be many reasons for this. It could be because hospitals get paid more in the outpatient department for the same services than those services would be paid for in a physician office. Another factor, which I think one of the previous speakers mentioned, was the 340B drug purchasing program, which reduces pricing on outpatient drugs to covered entities, including many hospitals, acute care hospitals, and cancer hospitals, which means that the drugs can be acquired by hospitals cheaper than they can be acquired by physicians, so the margins on those drugs may be higher for hospitals than they are for physicians. So MedPAC has been looking at this issue, and they've been recommending that we pay evaluation and management services, so visit services, at the same rate, irrespective of whether they are provided in the hospital outpatient department itself or in what we call an off-campus provider-based department, which really, to I think a patient, probably looks like a physician office, but it's a hospital outpatient department, and it's not on the campus of the hospital. And then they had pay other services meeting specific criteria at the physician fee schedule rate as well. CMS has been looking at this issue, and we've been much more focused on the off-campus provider-based departments because we look at them as much more similar to physician offices than to hospital outpatient departments, and are trying to gather data on how many services are provided in these settings. Right now, the place of service code on the claim is going to say hospital outpatient department, and the hospital claim is not going to distinguish between whether it's on campus or off campus. So we're working on collecting data to try to get a better information on this issue. And with that, I think I am done over time, and I think we're going to be going into a panel session anyway.